In 2021, sub-Saharan Africa carried almost 95% of the global malaria burden. Within that concentrated region, one nation bears the heaviest weight. Nigeria alone accounts for 27% of all malaria cases worldwide. The human cost of this volume is distinctly pediatric. In Nigeria, malaria drives 30% of all mortality for children under 5 years of age. This staggering volume of pediatric mortality is driven almost entirely by one specific etiology. Over 95% of these infections are caused by a single parasite species, Plasmodium falciparum. To understand why this specific species is so dangerous, we have to look past the population statistics and observe the mechanics at the cellular level. Plasmodium falciparum is lethal because of its mechanical behavior. It actively re-engineers the host's microvasculature, triggering rigid biological blockages that lead directly to systemic organ failure. The infection sequence begins when a female Anopheles mosquito inoculates sporozoites directly into the human bloodstream. This CDC diagram traces the parasite life cycle. Sporozoites mature in the liver, launching the human blood stages. Here, Plasmodium falciparum operates on a strict 48-hour cycle. Exactly 48 hours later, infected red blood cells, now mature schizonts, rupture violently, releasing massive waves of new myrizoites. This rupture also dumps a massive load of toxic cellular waste into the bloodstream, notably a compound called glycosyl phosphatidylinositol, or GPI. This sudden influx of GPI forcefully activates the host's macrophages and the endothelial cells lining the blood vessels. Those activated cells immediately secrete a flood of inflammatory mediators, specifically tumor necrosis factor, interleukin-1, and interleukin-6. This biochemical cascade is the direct cause of the classic malarial paroxysm. Interleukin-1 and IL-6 activate prostaglandins that physically alter the set point of the brain's thermoregulatory center, inducing the severe fever and shivering rigors seen in clinical patients. While the fever is severe, the true lethality of Plasmodium falciparum lies in its structural mechanics. It aggressively infects both mature and immature red blood cells. This diagram illustrates the host endothelium. While healthy microvasculature allows smooth blood flow, the parasite introduces massive structural alterations. Maturing into a trophozoite, it induces the formation of electron-dense knobs that push outward across the infected red blood cell membrane. These outward-facing knobs become concentrated with a highly adhesive protein called Plasmodium falciparum erythrocyte membrane protein 1, or PFEMP1. This protein acts as a biological anchor. Through cytoadherence, PFEMP1 binds the infected cell directly to the endothelial vessel walls. Simultaneously, rosetting occurs. Infected cells bind to uninfected red blood cells and platelets, forming massive, dense clumps in the bloodstream. For the parasite, this sequestration is an evolutionary survival strategy. Anchoring in the deep tissues provides a venous environment perfect for maturation, while physically preventing the infected cells from circulating through the spleen, where the host's immune system would clear them. But for the host, the results are catastrophic. Cytoadherence and rosetting drastically reduce red cell deformability, turning a parasitic infection into a lethal mechanical occlusion of the deep microcirculation. This table outlines the WHO's clinical indicators for severe malaria. These diagnostic thresholds are the direct macro-level result of those microscopic blockages. The most critical is cerebral malaria, marked clinically by an unarousable coma with a Glasgow Coma Scale score of 9 or less. This profound neurological deficit happens because the rosetting and decreased cell deformability create widespread thrombosis. The microcirculation in the brain becomes occluded, leading rapidly to cerebral anoxia and punctate hemorrhages. The mechanical blockages also drive another primary indicator, severe anemia, diagnosed when a patient's hematocrit drops below 15%. This anemia is severe because the rosetting mechanism drags healthy cells down with the infected ones. The spleen end up clearing massive numbers of uninfected red blood cells simply because they were caught in the clumps. This massive loss of red cells is compounded by bone marrow suppression. The toxic hemozoin pigment released during parasite rupture actively suppresses the body's normal response to erythropoietin. Because these mature trophozoites and schizonts are so effectively anchored in the deeper tissues, a standard peripheral blood smear will rarely show them. They are hiding in the microvasculature. The physician only sees the downstream devastation. The severe anemia and neurological failures seen in pediatric wards are macroscopic symptoms of this microscopic vascular hijacking. Because of the parasite's aggressive replication, all clinical suspicion of malaria requires strict parasitological confirmation. Light microscopy remains the gold standard, allowing technicians to quantify the exact percentage of parasitemia in the red blood cells. In field settings, rapid diagnostic tests act as a vital triage tool. While less sensitive than microscopy, they quickly detect species-specific circulating parasite antigens to confirm infection. For uncomplicated cases, the standard intervention is a 3-day course of artemisinin-based combination therapies. But once severe Plasmodium falciparum malaria sets in, definitive treatment requires immediate IV arsenate. For children weighing under 20 kilograms, a precise dose of 3 milligrams per kilogram is administered to rapidly clear the parasite and dissolve the rigid cellular clumps. This policy document outlines the AIM 2016 to 2030 strategic targets. Global frameworks like the Rollback Malaria Partnership have established clear mandates, aiming for a 90% reduction in global mortality. Hitting these targets relies on measuring and controlling the entomological inoculation rate, a strict metric tracking exactly how many infectious mosquito bites occur per person per year in hollow endemic regions. Eradicating malaria requires an unbroken chain of intervention. It demands neutralizing cytoadherence at the capillary level with targeted antimalarials, while simultaneously suppressing transmission rates across the environment.